Socié is located in Paris at Hôpital Saint-Louis, graduate of the University of Paris, where he got his MD and PhD degree. He has very broad interests and is clearly one of the leading people in the European community, transplant community, also actually with a keen interest and expertise in PNH. And in fact, we asked him to give a presentation on that topic.
I'm Gerard Socié. I'm from the Hospital Saint-Louis in Paris, in France. I'm deeply sorry not to be able to attend the meeting in person. It would have been really fun to see people at the Fred Hutch and friends in Seattle, but it's not possible. The CRH meeting has me to cover some part of PNH. I'm sure that a lot of you are aware of this. I decided to focus on most recent development. Next slide. To be quite simple, there is two diseases that's clearly overlapped. That's PNH and aplastic anemia. And for the purpose of this talk, I would be very quick on aplastic anemia, in which the patients might have a PNH clone, because basically this will be covered by Dr. Malley in this session, because basically patients with aplastic anemia, especially with severe aplastic anemia, in which you detect a PNH clone, must be treated as an aplastic anemia. And that's clearly outside of the topics I will cover today. And for those who have interest, the review by Neil Young in the New England Journal of Medicine in 2018 really covered the disease from the pathophysiology to the treatment. Next slide. Let's speak about PNH. PNH is a quite bizarre disease. It's rare and it's extremely heterogeneous. So if you look to presentation, patients present with abdominal pain, with unusual thrombosis, less frequently with infection. And when you look to the blood, although it's thought to be only a problem of anemia, you see in this slide on an old paper we published in 2008, that anemia alone is only 20% of the patients, and most of these have some anemia plus another cell lineage that is deficient. That could be anemia and thrombocytopenia, or more frequently, some degree of pancytopenia. This means decrease in platelets, in red cells, and in neutrophil. Next slide. The hallmark of this disease is the deficiency of an anchor, something that is like sugar linking a protein, and this sugar link the protein to the cell surface. And what is important to understand is that's not the protein that is deficient, but only the anchor that is in orange and blue in the left part of the slide. The diagnosis of PNH, as you know, is now done all over the world doing flow cytometry and more recently by FLAIR, but FLAIR is only a sort of slight different version of flow cytometry. Next. Since you like the anchor, it is called a GPI anchor, a lot of proteins are linked with this GPI anchor, but there are two proteins that are really important, CD59 and CD55. And these two molecules are key regulator of the complement. Thus, if you like the anchor, you like the protein on the surface, such the cells, especially the red blood cells, become highly sensitive to the complement activation. And when the complement activation is done, basically its role is to do some hole in the membrane of the cells that make the red cells to really explode. And what is in the red blood cells is basically hemoglobin. And when you have hemoglobin in the blood that is free and not in the cells, then it can go into the urine and give the classical sign of red, black urines, especially in the morning. Next slide. The fact that you have hemoglobin in the blood, that is called free hemoglobin, is of major importance because this leads with rather complicated mechanism to the major sign of PNH, that is thrombosis, renal failure, rare case of pulmonary hypertension, very frequent abdominal pain, less frequently chest pain, obviously dyspnea. But due to the biochemic of free hemoglobin, this leads to the decrease of another molecules called nitric oxide, or NO, and NO leads to the symptoms all of you know, that is dysphagia, fatigue, hemoglobinuria, or dark urine, and in men, erectile dysfunction. Next slide. We put probably more than 15 years ago, in 2008, the largest series that have been ever done in PNH because of the French registry. And we put data on more than 450 patients at that time. And at that time, you see that the median overall survival was 20 years, but you see that the curves was not clearly a plateau, and clearly patients died of PNH. Next. The real revolution was in 2006, a seminal paper by Pete Hillman in the New England Journal of Medicine using eculizumab. And eculizumab inhibit one fraction of the complement I spoke, that is C5, and this leads to a dramatic improvement of your life and on your symptoms. Next. And if you see what we published in 2016 in France, when you compare the survival of patients treated with eculizumab as compared to the old series, 1950 to 1984, or most recent control above the year 1985, eculizumab clearly improved survival to what was our previous experience. Next. And why it decreased survival? Mainly by 1 point, because it decreased dramatically the incidence and the severity of thrombosis. Again, back to our old series in 2008, you see that patients with classical PNH mean anemia or hemolytic anemia mainly. You see that the incidence of thrombosis might reach 50% of the patients by 5 years. This means that at least 50% of the patients are at risk of thrombosis. That could be life-threatening, especially if they occur in the liver. It's called the Budd-Chiari syndrome, or in the CNS due to venous thrombosis of the CNS. Next. And what was proved in 2007 against by us and the same group of people working on eculizumab is that using eculizumab drastically decreased the incidence of thrombosis. It's pre-eculizumab, you see nearly 40 events, and after the treatment, only 3 events occur. And it was clearly demonstrated in this paper in Blood in 2007, a more than 90% reduction in the rate of thrombosis using eculizumab. Next. And lastly, because it's quite old literature, what about survival overall? The one who had the greatest experience, or the longer experience with eculizumab is Pete Hillman in Leeds in the UK. And they perform a study in which they have very long follow-up, and they compare the survival of patients who have long been treated with eculizumab as compared to an age and gender matched general population, and you see that the survival curve is nearly the same. This means that patients with PNH treated with eculizumab experience now an almost survival rate that is the one expected in the general population. More importantly is, as you know, it decreased significantly the number of transfusion. But if you see the mean and not the median transfusion, you see that a significant proportion of the patients, I said 30% of the patients, even treated with eculizumab, still need transfusion. And that will be the main topics of the second part of my talk. Next slide, please. The second drug that was developed in the setting of PNH is a sort of long-lasting drug, or let's say, yeah, long-duration drug that is similar to eculizumab and developed by the same company, Alexion, and it is called ravulizumab. This drug has been approved in the United States, and in 2019, 2 papers in Blood in the same issue report the results of 2 randomized studies comparing eculizumab to ravulizumab, either in patients naive of any treatment with complement inhibitor, or in patients who have been treated by eculizumab and still continue to experience some problem with the transfusion or low hemoglobin level. Next slide. And this slide summarizes the main results of these 2 studies published in Blood. It showed that in treatment-naive patients, ravulizumab had similar efficacy in terms of LDH level and in the number of transfusion. And for patients already treated by eculizumab, that it improved, although not significantly, the LDH level. What is the main interest of ravulizumab, as you know, is rather than going back to the hospital every 2 weeks, now ravulizumab can be given every 8 weeks with similar efficacy as compared to eculizumab. But clearly, the main advantage of the ravulizumab drug is the ability to have long-lasting efficacy, allowing to have infusion nearly every 2 months. Next slide. Is that all the game? Certainly not. We published back in 2015 now a small study published in Blood in which we show that despite eculizumab, if you look to complement activation, a significant proportion of the patients still have complement activation and not blockade, despite eculizumab. This could be due to reduced hemolysis in the blood, that is called intravascular, or to the fact that red blood cells might be destroyed in the tissue and not in the blood, and this is called extravascular hemolysis. On a practical background, we can say roughly that there are, with eculizumab and probably with ravulizumab, 3 situations. Let's say in 1/3 of the patients, they are doing perfectly well. They have a hemoglobin not really normal, but clearly above 10, that they can enjoy a normal life. In 1/3 of the patient, hemoglobins vary between 8 and 10 and need sometimes to be transfused. And unfortunately, in 20 to 30% of the case, some patients still need regular transfusions, as this means there is clearly a room for improvement. Thus, next slide. This comes to a different company to ask the question, can we block the complement at different stage? And basically, if you go to the left part to the right part of the slide, the beginning of the complement activation basically start with C1, and the left part to what is called the MAC, that is the machine that allowed to make a hole in the membrane, and it is C5. And now if you look next, how can we block this along the pathway? Is there any drug that can act differently as compared to eculizumab? Next. This has been the case. Again, eculizumab and ravulizumab block C5, and now 3 drugs mainly are developed at different stage, clearly at different stage, blocking, let's say, earlier in the activation of the complement cascade. One drug blocks C3, another drug block factor B, and another drug block factor D, and we have some evidence that they might be useful. Next slide. The first one is pegcetacoplan, that I cannot pronounce, obviously, as a French, but let's say it's an anti-C3 inhibitor. It has been published early this year in 2021, and my colleague Régis de la Tour is last author of the paper for our group in Saint-Louis. These anti-C3 molecules that still need IV infusion have been developed using the schema you have on the bottom part of the slide. Let's say you start with both drugs, the anti-C3 and eculizumab, and after some time, let's say 1 month, you stop either eculizumab or the anti-C3, and basically you see what is the drug who will win the game. Next slide. And clearly in this randomized study, the results is quite straightforward, although be careful, the number is not so huge. You have, let's say, 40 patients in each group, but clearly the anti-C3 antibody in those patients who are on eculizumab and have an hemoglobin level less than 10.5, despite eculizumab, those who are giving the anti-C3 drugs increase their hemoglobin level by, let's say, 2 grams. And basically you see that roughly patients have around 8.5 grams and rise to 11.5. Next. And this is shown differently in the same paper, showing a superiority in the change from baseline in hemoglobin level. And the bottom part of the figure showed that the number of patients free from transfusion shows clearly a non-inferiority and basically a superiority of the anti-C3. These anti-C3 drugs has been very recently approved in the United States by June 2021. Next slide. I will now speak briefly about 2 drugs. These are very early development. That's be careful. We are moving from 100 of patients to 40 per arm with the anti-C3, and now we speak for the 2 last trial on 10 patients. That's interesting, just giving you information, but be careful, it's only 10 patients. The first drug is an anti-factor B inhibitor. As you see, it acts much earlier than eculizumab. And in 10 patients who have been treated with this drug, there was impressive rise in the hemoglobin concentration after giving these drugs, because the increase from baseline is now more than 3 grams per deciliter. Okay, and that makes real sense, because you see that you have now being able to reach nearly normal hemoglobin level. And obviously, when you reach normal hemoglobin level, you don't need to be transfused. They showed in figure 2. You have, for example, these patients who had, in the year before study entry, 40 transfusion a year. That is now completely off any transfusion, and that's really impressive. The second thing, and again, be careful, 10 patients, only phase 2, just to be sure that it's a proof of concept, it's well tolerated and not too toxic, and that is the case, but it's still 10 patients. But the main point here is that not only is it efficient, but it's an oral drug, it's a pill, it's no more an infusion. Next one. And finally, about this drug, that is, again, a word in English that I cannot pronounce, but it's an anti-factor D. It's a factor D inhibitor. Again, 10 patients, be careful, seems to be interesting, but here again, the annual number of transfusion decreased more than significantly using the anti-factor D. Next one. Just to conclude, if we can conclude, you have the gold standard. The gold standard is clearly eculizumab. We have now more than 15 years of follow-up with this drug. We know we can use it. We know that it's safe, provided that you get vaccination. In France and in Europe, we use also antibiotic prophylaxis that I know that is not usual in the United States. You have the new drug formulation, ravulizumab, that is drug approved in the United States, not yet in Europe. The main advantage is with the same efficacy, you have to get your infusion only every 2 months. Is clearly decreased thrombosis, increased survival, but 1/3 of the patients still need to be transfused. What about potent future treatment, new proximal complement inhibitor? Overall, it seems that is normalize or nearly normalize the hemoglobin level. Thus, patients can really get rid about transfusion. Be careful, you block the complement pathway very early, and there is no doubt there is a potent increased risk of infection using these new drugs. Especially there are some clear attention of the physicians community to the risk of what we call breakthrough. And you know what is breakthrough. Basically, you have PNH, you receive Soliris, and you get a flu or a gastroenteritis, and then you have massive hemolysis. That is what we call breakthrough hemolysis, while you get complement inhibitor. The big deal with these new proximal inhibitors is that since you really block the complement, if you have a breakthrough, there is a risk for massive hemolysis. That's why we're very, very careful with that. As I say, 2 of the drugs I mentioned are only in very early development. So it was only for your information. And basically for all 3 new drugs I talk about, we clearly lack follow-up to have real experience of using the drug. Next slide. And with this slide, I was really thanks Joachim Deg from the Fred Hutch and all the community and the MDS-SAA Foundation for asking me to give the talk for you today. Again, I would love to see you face-to-face in Seattle, but it's not possible. You know, all the people who work in our group in the hospital St. Louis. I will not be able to answer to your question because you will ask your question basically in the middle of my night, but I'm sure that other physicians will be able, and if you have no response or want to communicate with me, it's quite easy. My email is gerard.socié@aphp.fr. Have a wonderful day and hope to see you all soon. Bye-bye.